Hello, I'm Stephen Knoll. I am the program director and currently serving as the interim chair for the Department of Medicine, and I welcome you to our overview of the residency program within the Department of Medicine here at Upstate Medical University. Our Department of Medicine mission and vision I've laid out for you here. Our mission is to promote and advance the health, knowledge, and wellness of the people we care for and about through clinical care, education, outreach, and scholarship. But what do we aspire to be? Well, that's our vision, and I've laid that out here. Through collaboration with our institution and community, Upstate's Department of Medicine will provide responsible, innovative, and compassionate care and education to our most valued asset, the people we serve, and let it be a blueprint for other healthcare systems around the country. We look now more specifically at the residency program within the Department of Medicine. This is the agenda that we'll be covering in our time together. If we start off with the Educational Programs Office, these are the individuals whose responsibility is to develop the curriculum and to oversee your training overall. You can see there on the bottom, sort of that stick figure, we have two VA quality chief residents, one of which, though, is brought in from the outside by the VA, and we don't yet know who that will be, so stay tuned. What is our training mission? So I've laid that out for you here. Number one is to train outstanding clinicians and scholars, and I believe we have both objective and arguably subjective measures to indicate that we've done very well. Our board pass rate has been outstanding, and if you look at where our graduates go when they're done, whether it be into primary care, hospitalist medicine, fellowship, whether it's in an academic or private arena, we've done very well. I think our success with Mission 1 rests with the importance we place on Missions 2 and 3. So providing you with an environment where you can flourish, where you can develop relationships that are long-lasting, to provide you with mentorship, very, very important. We'll come back to the Social Wellness Committee a bit later. Our three hospitals I've highlighted here. In the center is University Hospital. It is a hospital that is primarily to serve the underserved. It is a state institution serving as a safety net hospital for a very large region of New York State, that yellow, or that red dot that you see in the middle of that yellow. So about a third of New York State is served by University Hospital. All services are covered by our training program at our primary site, and about 60% of your time will be spent at University. Our neighbor, the VA hospital, is serving an entirely different population, our veterans. About 30% of your time will be spent there. And again, all services are covered at the VA. And then finally, our other neighbor, Crouse Hospital, which is a private hospital. About 10% of your time will be spent there. And in Crouse, it'll only be in the critical care arenas. So you can see three hospitals, all with very different patient populations that are being served. So you have a very, very robust but varied clinical experience while training here at Upstate. This is the map of the institution, and you can see that University Hospital, Crouse Hospital, the VA Hospital all surround the medical school, Weisgarten and Setnor Halls. Outpatient experiences are predominantly at University Healthcare Center, UHCC. However, what you see here is that there is some new building going on. That's always a wonderful thing to see, right, when you are improving the physical layout of your campus. So infrastructure here has been very important. We've invested heavily. So a new ambulatory center will be opening probably in the spring of 2023. So your training, you will find that your outpatient experiences, your continuity clinic experiences will be moved from UHCC to this new ambulatory building called the NAPI Longevity Institute. It will be physically connected to the hospital as well. So that'll be nice when you have more inclement weather. You don't need to be outside. Another nice thing that you can see when you look at this campus map is that everything is really close, so that it's sort of a one-stop shop for all of your experiences. And You guys are reviewing programs, and after you have submitted your rank order lists, you'll be asked to provide some feedback on some of the things that are very important to you in deciding where to train. And I always try to hit on all of them during these presentations. Parking happens to be one of them. That's why I'm showing the parking garage here. I'm not showing it to you because I think it's an architectural masterpiece, but you will park right on site. And we look at the city of Syracuse just to highlight some of the sort of areas of interest. So you can see that Upstate and Syracuse University highlighted there by the dome, although that picture is a little outdated now as they have redone it, and actually they've just renamed it. But SU and Upstate are adjacent to one another. They sort of share Marshall Street, sort of that college town kind of life, a lot of eateries and whatnot during the day. Also some nightlife there, but there's also I would say, a more appealing nightlife, perhaps for ourselves down in Armory Square. There's the big shopping, Destiny, a major mall in the United States. And you can see then in the background there the shores of Onondaga Lake. If we look at more in depth at our residency program, how many house staff I've listed for you there. If we look at salaries, these are the salaries as of July 2022. And, of course, salary is important, but I would caution you to think not about salary, but think about the value of the salary and the market in which you'll be making it. And so I show you here, if we compare a salary of $56,000 and what that'll allow you to live like in Syracuse, what would your salary need to be in other markets to live equally? And so you can see here that it actually costs a little less to live in a market like Cleveland. And Cleveland has some excellent programs. All these areas I'm showing you have excellent programs. But you can see as an example, if you want to train in a market like New York City, you would need a salary of $142,000 to live like you could live on a salary of $56,000 in a market like Syracuse. So if that's important to you, you can do a cost of living comparison. Best Places is the website that I used, and I would certainly encourage you to take a look at that. If we look at other benefits that we offer in the residency program, I already touched on parking. Yes, there is educational and scholarship support that you see listed. Yes, we do provide you with food for lunch and if you happen to be on call. And we also will purchase and launder your white coats. And all of these make your top 10. If we look at our curriculum in a little more detail, our format is very different than I think many of the programs will visit. And this is about deciding what you think works best for you. So I trained in what I describe here as the sort of more traditional or older format. And I look at it as a tug of war. It's where you're saying on a service, and while on that service, you need to do a half day of clinic, maybe 2 half days of clinic each week. So you have to interrupt whatever it is you're doing. You need to leave to go to your outpatient. It creates the need for handoff. You got to leave, handoff when you return. Handoffs are generally when we see more opportunity for error. So I don't like that. You have to add more time to your day because you're likely leaving your inpatient work, which is unfinished, and have to return after your outpatient work to finish, which then also means that it's hard to focus on your inpatient or outpatient because what you're thinking about is the unfinished work in the two arenas. So I cut this sort of rope and relieved the tug of war by developing a new system. And it is a block format. Were we the first? No. Were we one of the first? Yes. But the system that I created was the first type within the block format, what I've called the 3+1, which is still not a very popular form. Most will have block formatted that are a 4+ or 6+ model. So let me describe for you. So on this slide, if you are pursuing a categorical track. What you see here is each categorical house officer in their PGY 1 year, and they are separated into four groups, each with 9 individuals, 9 times 4, 36 interns. And what you see are these sort of this skeleton of CC. And that CC skeleton repeats itself in a 4-week cycle. So what happens during CC? CC is an all outpatient continuity clinic, CC. So during that week, you spend doing 5 half days of continuity clinic, and then we've created 13 additional CC experiences because you have this in a 4-week cycle. 13 times 4 is 52 weeks in a year. So as an example, maybe you're doing CC and during the week, you're going to do your 5 half days of continuity clinic. That will always be the case. But during this particular CC block, you're going to spend 5 other half days doing all things outpatient cardiology. Next time, you'll come back, you'll do 5 half days of your continuity clinic, and then the other 5 half days will be all nephrology, outpatient. So each of the specialties in an outpatient arena, but also other parts of the curriculum will be delivered through the CCPs. For example, maybe it's a week of the other 5 half days being spent on POCUS training or other simulation or communication. So that is the CC. That happens each year. When you're not on CC, the rules that I created are when you are doing an inpatient team or ICU, it's a 2-week rotation. No more and no less. When you do any other service, whether it's a required service, whether it's an elective, whether it's research, they are all built as 1 week, non-repeating, except for elective, which can repeat and which you can convert to research. So if you look through this, you'll see that there are times in here where elective is just 1 week, but then there are other times where you see it as back-to-back, and then there are other times where you see it back-to-back. And that is how the 3+1 has been built. And I find this to be a better system because, one, it removes that tug of war. So it reduces stress, reduces the risk of burnout. It promotes wellness by sort of relieving that stress. You focus on inpatient, you focus on elective, you focus on research, you focus on outpatient. It relieves the risk of quality and patient safety issues because now we've cut down the number of handoffs. It's reduced your time per day that you would otherwise see if you were in that tug of war because you've now relieved the inpatient and outpatient. It's inpatient or outpatient. For prelims, it's a little busier slide. The prelim schedule is crafted with the same type of rules. However, prelims are not doing a CC because they're not going to be here for 3 years. So continuity clinic for 1 year is of little value, both for the learner, you, but also the patients who would have to continue to switch to a new provider each year. So I still say it's 2 weeks for an inpatient ICU or team, but it's possible you could transition to a different team from a team that you've just left. And that's because I have to ensure you have enough internal medicine. If you're not getting it through the outpatient arena, then I have to give it to you through the inpatient arena. But because you're going to do more inpatient time, what I've given back to the prelims is more elective time. And that's what you can see here, which is a very busy slide, but it's to show you 2 things. One, when we look at the categorical and prelim averages, the time that the prelims are spending in the inpatient side is more than the categoricals, but that the amount of elective time for the prelims is greater than the categoricals. And that you can see here. This is just giving you a snapshot of each year, roughly the number of weeks that you'll be spending on each of the types of services. Vacation is 4 weeks per year. It's assigned in blocks for the interns, both categorical and prelim, but for the 2s and 3s, they can choose their vacation with whatever frequency. If we look at elective time and what you can do on elective, well, the things that you would think about as common electives, we certainly have because we have all of the specialties to offer them. But other things that may not be something you would normally think about. As an example, I run a metabolic stone clinic, and you can rotate if you wanted in this metabolic stone clinic. So the chemistry of stone formation. We have a transplant program if you wanted to rotate, for example, in the kidney transplant. If you have a desire to do more in the way of procedures, okay, there's an elective for that. If you'd like to spend more time perhaps in infectious disease working with the HIV population, we have an HIV clinic. We have a large refugee population here in Syracuse, and if you have a desire to do more times with the refugee population, there's an opportunity to do it. There's an away elective opportunity at the NIH. That's for the 2s and 3s only. We do have a transgender clinic if you'd like to spend more time there. We have a pulmonary hypertension clinic, a cystic fibrosis clinic. We have a hepatology clinic. So these are perhaps some additional offerings that you wouldn't normally think about in your training experiences. Call, I've tried to craft so that it's similar between the institutions where it can be. So, for example, when you're on floors, call is very similar. When you're in critical care, call is fairly similar. Our only 24-hour call is for our PGY3s and only in the Krause ICU. The PGY1s and 2s do not do any 24-hour call. The other piece I would add here is if an intern is being asked to provide call, then we have a senior on that identical service also participating in that call. And if an intern is providing call, it mandates that there is also in-house attending support. Now, a word about what I'll call backup, or some of you hear it as jeopardy. So, well, what about if somebody is, on a service and God forbid is ill, or perhaps is interviewing or presenting at a national meeting? Who provides the coverage? Well, in those situations, we have to ask somebody else to provide that support, that coverage, and that's a person that we have listed on the backup or jeopardy system. And we try to fairly distribute the jeopardy so that it's being shared equitably. If we turn an eye towards scholarship, remember Mission 1, this gives you a sense of how productive we've been, despite COVID, how productive we've been in the area of scholarship for the core house staff. On the way of didactics, even though most of your learning is going to happen at the bedside, which is where it should happen, you do need to ensure that there is still a formal curriculum in place. And so this highlights that formal curriculum. And it doesn't matter whether you're on an inpatient service, an outpatient service, a required service, an elective service, you will have at least 1 hour every day of formal education delivered to you through the curriculum. And I'm not going to review each of these, but you can review all of these at your leisure. If we are not able to do them in person, which, with COVID has been a challenge at times, then we offer these through a virtual option, and we predominantly use Zoom here at Upstate. But we also have Microsoft Teams, WebEx. If we look at some things that we do that are perhaps a little different, maybe innovative, so as an example, we have a Department of Bioethics, so we have an annual sort of afternoon retreat where each class has its own retreat, and the class is responsible for actually developing the curriculum for that particular retreat, which is good because it gives you an opportunity to craft your own education as it relates to bioethics. EMIM report, so for 2 Fridays of the month at our noon report, we instead scratch that off and we bring in emergency medicine, and we ask for Internal medicine to present a case that emergency medicine asked internal medicine to admit. And we ask emergency medicine to present a case that they then asked internal medicine to admit. So now we're going to have 2 cases, each 30 minutes, each presented by each of the departments. And that gives us, in both departments, an opportunity to learn from one another, to help with improving quality and relationships between the 2 departments. And I'm very big on relationships, which is ultimately why I started this. You get to know the people within emergency medicine and they, us, right? You get to know them on a first name basis. You get to hang out. You get to have lunch together. The likelihood is it's going to make for a stronger working relationship. POCUS, so we have a POCUS curriculum, and our vice chair for quality and one of our associate program directors, Dr. Gambier, has worked very diligently to develop this. And it is a 1-week course that will happen each year. There is also, in addition to the course, POCUS offerings through rotations that you're doing both in the ICU and the floors, but also what you see below there is the procedure team. So the procedure team is separate. It's sort of a dial 1-800 procedure. You're rotating on that. People are calling you to, hey, could you please help me with a paracentesis? You're working with advanced practitioners and faculty, and you're utilizing POCUS. But again, the point of the procedure team is, it again is sort of to reduce that tug of war, that stress. Oh, I've got to get a procedure done, but I also have my inpatient notes, and how am I going to get that done? I can breathe. I can ask one of my colleagues rotating on the procedure team to do this, and you'll then rotate at some point on the procedure team, and that's all you'll do during that time is procedures. Okay? So again, it focuses your educational experience, reduces stress. The RRT code team at university is very similar in its design. It's if there's an RRT, rapid response, or a code, if you're on, in many programs, when you're on call, the call team is the code team. Well, again, it adds stress. And how do I manage that and manage my call responsibilities? So we have a separate team to provide that support. 2020, so when you're in your continuity clinics, if you look at, nationally, if you schedule, say, 5 patients to show, the show rate generally is not 5 out of 5. It may be 3 out of 5. So if you're talking about a 60% show rate and you're there 5 half days a week, that's 25 patients with 15 patients showing. I believe we can do better. We need to do better. So I developed what I then came to term the 2020 system, which was we will cut our in-person by 20%. So from 5 half days to 4 half days, but that 5th half day, my house staff are going to actually reach out and connect to their patients to just sort of check in on them. How's it going with the recent chiropractor? How is that new insulin pump working for you? Hey, where do things stand with that MRI? I believe if you connect with your patient beyond the 4 walls, right, they're going to want to come back to see you. Think if you were the patient and you got that kind of outreach from your provider, would you want to go back to see them? So the goal was cut by 20%, but maybe we can then, by doing so, grow the number of patients that show by 20%. So instead of 3 out of 5, you go to 4 out of 5. So that means that instead of 25 being scheduled with 15, okay, maybe now we will schedule 20, but we can get 16. Well, 16 out of 20 is better than 15 out of 25. And so we put that into effect years ago, and we have a show rate that now hovers somewhere in the 85 to 90% range. So you're getting now a little more in your outpatient experience, so that makes for a better experience, makes you better prepared for a career in outpatient if that's your desire. It's better for our patients because they're getting connected to their providers, which hopefully reduces the need to go to urgent care and emergency rooms. And at the end of the day, it's also a win for the institution, right? Because it's volume that generates revenue. Telemedicine, we certainly didn't develop telemedicine, but we certainly have incorporated telemedicine into our curriculum, and certainly more so because of COVID. But one of the innovations that came out of our own house staff was in the beginning of COVID, when we had patients that couldn't have family visiting them, right? They were confined to their rooms. Everybody had to PPE, and you wanted to reduce your PPEing because there wasn't a lot of PPE. The house staff came up with the idea of, well, why don't we have iPads for each room so that the patients can communicate not only with their providers through the use of the iPads, but they can also communicate with their family through the use of iPads. So that was a telemedicine innovation developed by our own house staff. In the world of simulation, procedures, and mock codes, yes, we do all of that. Communication is something I'm very, very passionate about. So our Learning to Talk program, our education through theater arts program, are opportunities to improve your skills, both communication, cultural awareness, to have a better understanding, for example, of healthcare disparities. Rotation X is our name for our quality rotation, where you will spend time learning more about the business of medicine, working with utilization management, coding and documentation. You will spend afternoons becoming hopefully more adept as a teacher, as an educator, because we will supervise your teaching skills of the medical students. So Rotation X is really an opportunity to build on your understanding of the business and quality and patient safety, as well as the role of teacher. College Bowl is sort of the fun event of the year. We break into teams, and sort of like Medical Jeopardy, and the ultimate winning team gets what we call the College Bowl. It's this 40, almost 50-year-old silver bowl filled with candies, and the candies aren't 50 years old. We do change those out each year, but it's a lot of fun. If we go to wellness, right, and that's sort of a very important area right now, especially in the situation healthcare providers find themselves in the world of COVID. Hopefully you can get a sense that the program has, even before COVID, tried to understand the importance of wellness and to reduce stress and burnout by how it's changed the curriculum, the 3+1 from the traditional model, for example. Well, you know, it's important to also make sure you have opportunities to manage your time outside of your professional obligations. We build that into the curriculum. MICUJ and wellness is one example of that. We also have wellness days when you're on CC. But beyond that, there's also opportunities to just sort of do check-ins. So we've adopted the well-being index that the Mayo Clinic has offered so that you can do a sort of a self-check. And if you're finding that you need support, everybody in the program is here to support you. And so if you're looking for opportunities to discuss that with us, our doors are always open. If you're looking for something more formalized, then there is opportunities to do that through the RFCS service, the Resident and Fellow Counseling Service, which is provided to you by the institution. And then there's opportunities to connect both, you know, socially, but also with the community. And I believe community outreach is vitally important, not only for our community, but for ourselves. Doing good for others makes you feel good. And so World Women in Residency Life has really developed into a gem, and what they're offering is just one example of how we connect with our community. And then you see all of these photos, but these obviously highlight a lot of in-person, no masks. This is pre-COVID times. Well, COVID hit, and you know we had to think differently. We didn't want to abandon our opportunities to connect. We just had to change how we connected. And so you can see the social committee came up with ideas how to connect, maybe through virtual means, but still an opportunity. The recognition event we couldn't do in person, but instead we did it at a drive-in, and we produced the recognition event as a movie, and we showed it on the big screen, and people could come in their cars and picnic and everything else. So again, you can't ignore this. You have to embrace it. COVID has certainly provided, you know, somewhat of an obstacle, but it's an obstacle that's overcomable. You just have to be willing to commit your resources to doing so, and we believe that we have. And when you're done with your training, you know, I'm not looking to develop the personality of House, right? But you want to say, yep, I'm ready. I can manage in just about any clinical situation when I'm done with my training. That's the goal, to make you feel, and to not just feel, but in reality know that you are able to practice independently. And so I think of three sort of avenues you can take. Now, the first, you may say, well, you're biased, a chief resident. And I say, well, okay, maybe I'm biased, but if you look at leaders in academic medicine, most of them were chief residents. And if you're thinking about, well, I think I may pursue a fellowship, it's like, okay, that's fantastic. But remember, I just said most leaders were chiefs. And so if you're going to accuse me of bias, of, pushing the role of chief, well, perhaps they're biased towards chiefs. So chief is not only a wonderful addition to your CV, but it really is the foundation upon which a career in academics is built. So I strongly encourage a chief residency here. It's why we have so many different chief offerings. If you want to move into hospitalist medicine, primary care, absolutely. There's opportunity to do that here. You'll be well prepared to do that wherever it is you would ultimately like to go. If you'd like to do a fellowship here at Upstate, these are the fellowships that we offer training in. So hopefully with that overview, you feel like you have a pretty good understanding of the program at this point, but I would certainly encourage you to explore the website further. There's a lot there to see. There's tours as well. And hopefully we'll have the opportunity to meet, whether it's in person or virtually, the opportunity to meet and hopefully come together in the future for your training. Thanks so much for your time.